Good evening, all.
Good evening.
Shall we start the session, ma'am?
Yeah, we can start.
Okay. I would like to introduce our moderator for today's case presentation, Professor Preetha Ramprasat, ma'am. Ma'am is a distinguished optometrist, academic leader, and clinical researcher with over 24 years of experience in optometry and vision science. Ma'am currently serves as a professor and principal and M-Optom course coordinator at Wasan Institute of Ophthalmology, which is affiliated with Tamil Nadu Dr. MGR University. Ma'am is currently a president of OATN. Ma'am holds MS in physiological optics and vision science from University of US and BS from ESO. Ma'am has a lifetime fellow awardee in 2025 and she has also awarded as Washington Best Educated Award. Ma'am has monitored 80 plus students in research products in the research projects and she is a beautiful mentor for contact lens training modules and she's our moderator for today.
Welcome, Preetha.
Welcome
Thank you,
to the
ma'am.
session.
Thank you. I thank Dr. Jemima for inviting me as a moderator to moderate this session.
Thank you for accepting our
Thanks
invite.
to the
And it's
group.
really a privilege to have a person with years of experience as a senior optometrist who is joining us. So, students, please make use of this session and you can learn the maximum.
Final year, studying BOPM final year from Wasan Institute of Ophthalmology presentation. Now I am going to present a case which is a 22 years old female patient visited our Crumpet branch on 14/11/2025 and her work is system-based work. She came with the complaint of redness for last 1 week associated with the pain for past 2 days in the right eye with the complaint of watering and glare will present that morning using the actual lens which is monthly disposable contact lens monthly contact monthly disposable contact lens into 5 months and she used a CL today morning 1 hour ago and she removed the lenses due to the redness. All other details regarding the contact lens usage are not available. Next, general health is normal and current treatment is nil and allergy history is not aware of any. And her vision is 660 and her guided vision is 660 and near vision is N6 at 40 centimeter in both eyes. Next, slit lamp examination. Appendages shows normal in both eyes and conjunctiva shows ciliary congestion in both the eyes. Sclera shows normal. In cornea, shows positive fluorescent staining in both the eyes with marginal stromal infiltration at 4, 7, 8 o'clock position in right eye with overlaying epithelial defect and piece which means punctate epithelial erosion in left eye, positive fluorescent staining with the marginal infiltration at 12 o'clock position with some of the piece punctate epithelial erosions and in anterior chamber shows normal depth, pupil shows round and center, lens is clear and iris is within normal limit. Next, the provisional diagnosis both eye contact lens induced marginal keratitis and doctor advised medications Vigamox 8 times a day for 1 week both the eyes and Hyalurich 6 times a day for 1 month both the eyes and Aquam gel 1 times a day for 2 weeks both the eyes and T-Lims tablet for 2 times a day for 15 days and homemade drop for 2 times a day for 5 days in right eye. Recommendation: avoid contact lens, avoid eye makeup for 3 weeks, adequate eye rest for 2 weeks, maintain eyelid and hand hygiene, and to start steroids after epithelium heals, review after 3 days. Next, second visit on 17/11/2025. 3 days after first visit, patient came for follow-up for marginal keratitis in both eyes. She came with the complaint of pain for 1 week, but better than the before. And her vision is unaided vision is 660 in both the eyes, and near vision is N6 at 40 centimeter. Next, ma'am. Slit lamp examination shows appendages are normal. In conjunctiva, left eye congestions are healed. Left eye congestion are healed. In right eye, ciliary congestion remains. Sclera shows normal, and cornea shows positive fluorescent stain in right eye with piece and marginal keratitis at 4, 7, and 11 o'clock positions. In left eye, piece only seen, and in anterior chamber, normal depth. Pupil is round and center, and iris is within normal limit. Lens are clear. And then patient was advised for nuisance, see doxy 2 times a day for 5 days, and T-pen tablet for 2 times a day for 5 days before food. Zaha ointment for 1 times a day for 2 weeks in eye. FMLT drops 2 times a day for 2 weeks both eyes, and homemade drops for 2 times a day in right eye only. And then patient was asked to discontinue the hyaluronic drop and the aquamine gel, and recommended for the eye rest for 1 week and avoid eye rubbing contact lenses. Next, ma'am. In third visit on 2011-2025, first week after 1 week after first visit, and she kidness which is on and off since 1 day, and her vision is 660 and pinhole vision is 69 plus. Near vision is N6 at 40 centimeter for both the eyes. PGP is and refraction is not done due to the ma'am. Can I repeat, ma'am?
Yes.
Third visit on 2011-2025. 1 week after first visit, she came with the complaint of redness, which is on and off since. And the unaided vision is 660 and people vision is 69 plus with near vision of N6 at 40 centimeter for both the eyes, and PGP is nil. Diffraction is not done because the patient came with complaint of redness. Next, ma'am. Ma'am, can you change next slide? In slit lamp examination, conjunctiva healed and appendages shows normal, sclera remains normal. In cornea, right eye shows positive fluorescent staining with marginal infiltration resolving, and a few P's are seen in the right eye, but better than the last visit. In left eye, fluorescent staining is positive with a few SPKs, which is a superficial punctate keratitis, and P's are resolving. Anterior chambers are normal and normal depth, and pupil is round and center, and iris is within normal limit. Lens are clear. Next, ma'am. And doctor advised continue the same medication as advised earlier, and avoid contact lens until review. Avoid eye rubbing. Do not stop the medications until review. After this, patient did not come for review. Next, ma'am. Now I am going to explain my diagnosis, which is CL-induced marginal keratitis. Marginal keratitis is an inflammatory disease which occurs in peripheral cornea. It is characterized by a peripheral stromal infiltrates, which are often associated with epithelial breakdown and ulceration. And it is usually associated with the presence of blepharoconjunctivitis and is thought to be represent an inflammatory response against the RS antigen. And the symptoms of and the symptoms of marginal keratitis is pain, foreign body sensation, photophobia, and conjunctival ingestion, watering. Here's some of the pictures of marginal keratitis. Next, ma'am. Now contact lens complications. As we know, contact lenses are used to correct the refractive errors and improve visual acuity and cosmesis. Contact lens complication occurs due to ocular conditions or health issues that arises directly from or aggravated by the wear and care of contact lens. Improper use of contact lens can cause numerous complications which are manifested as clinical signs and symptoms. Here's some of the pictures which shows the common contact lens complications. Next, ma'am. Common cause of the contact lens complications are poor hygiene, improper fit or lens design, and lens material, solution, environmental factor, and reduced oxygen. Next, ma'am. Next is types of complication. It is subdivided into two: non-infectious complication and infectious complication. First, non-infectious complication, it is subdivided into three: lens related, lens care related, and wearer related. First, lens care related, it is caused due to the lens dryness, hypoxia, deposits, and poor surface, poor fit, and mechanical factors, etc. Some of the examples are 3 and 9 o'clock staining, corneal edema, neovascularization, CLPC, which is contact lens papillary conjunctivitis, and unstable vision. Next is lens care related, which is caused by solution sensitivity, expired solution, and dirty cases. Examples are SPKS, which is superficial punctate keratitis, infiltrates, and inflammation. Third one is wearer related, which is caused by poor hygiene, dirty overwear, and lack of motivation. And examples are infiltrates, inflammation, CLAR, which is contact lens acute red eye, and marginal keratitis. In infectious complication, which is a sight-threatening complications, the factors are non-infectious condition plus poor hygiene, and it is non-compliance. The causes are bacteria, virus, fungus, and parasitic amoeba. Examples are microbial keratitis, bacterial, viral, and fungal keratitis, acanthamoeba keratitis, and peripheral ulcers. Next one. Next one is non-infectious complication. First, I would like to explain the non-infectious complication. It is majorly classified into three: hypoxia-related and inflammatory and allergic reactions, and mechanical and physical issues. First, I would like to explain the hypoxia-related issues: corneal edema, corneal neovascularization, and microcyst. Corneal edema is nothing but the swelling of the cornea caused due to the insufficient oxygen, and it is a reversible condition with higher oxygen permeability lenses. Next, corneal neovascularization, then growth of new blood vessels in the cornea, and it is response to the chronic oxygen deprivation. Third one is microcyst, which are a small dots seen in the corneal epithelium that indicates the long-term metabolic stress. And here the pictures for the corneal edema, corneal neovascularization, and microcyst. Next is inflammatory and allergic reaction. First is CLPC, which is contact lens papillary conjunctivitis, an immunological reaction often to lens deposits, and it is characterized by bumps on the inner upper eyelid and itching and mucus productions in the eye. And some mechanical factors will cause a GPC in the rigid lens wearer. Then second one is sterile corneal infiltrates. It is an inflammatory cell clusters in the peripheral cornea, and often an immune response to the bacterial endotoxins or solution preservatives. The third one is CLAR, which is contact lens induced acute red eye. It is an inflammatory reaction often from sleeping with the Cl and causing redness and irritation. Here are the pictures for CLAR, corneal infiltrates and GPC. And third, mechanical and physical issues. First one is corneal abrasion, which is a scratch on the cornea, but it usually occurs due to trauma and also occurs during the lens insertion and removal, and a foreign body trapped underneath the contact lenses. And second one is corneal warpage. It is a change in the corneal shape due to a prolonged lens wear, and it will lead to irregular astigmatism. The third one is dry eye syndrome. It is a very common issue where the lens disrupt the tear film, and it will lead to irritation and dryness. And symptoms and signs. Symptoms are dryness and grittiness, redness, itching, and light sensitivity, then excessive tearing, mucus discharge, and blurred vision, then decreased lens tolerance. And signs are redness, epithelial defect, corneal edema, GPC giant papillary conjunctivitis, lens deposits, and ptosis. Next, ma'am. And the treatment or immediate removal. The first step has the patient to stop wearing the lens at the first sign of trouble like redness, pain, or discharge. And second one is lubrications. Use preservative-free artificial tears. And third one is hygiene and care. Reevaluate the cleaning routines and switch the solution into hydrogen peroxide. Then lens fit and type. Modify or adjust the lens fit and movement, and switch to daily disposable or differential materials. Then medications. Use preservative-free drops and potential steroids to reduce the inflammation, and anti-allergy drops. Then follow up. See an eye care profession to identify the cause and recurrence and prevent the recurrence. And next one is infectious complication. Next one, keratitis. Keratitis is the inflammation of the cornea, and it is characterized by corneal edema and infiltration of inflammatory cells, then ciliary congestion. And it is associated with both infectious and non-infectious disease, and it may be localized or systemic to the ocular surface. Contact lens wear is the most common established risk factor for bacterial keratitis in developing countries. Then all type of contact lens have been linked to infection, but with extended wear soft contact lenses conferring a greater risk than the daily wear hard or soft contact lens. And types, next ma'am. And the types are bacterial, protozoal, fungal, and viral. Bacterial keratitis causative organism is Staphylococcus and Streptococcus. Protozoal keratitis causative organism is Acanthamoeba, and fungal keratitis causative organism is Aspergillus and Candida, and viral keratitis herpes simplex virus and adenovirus. Last one is peripheral ulcerative keratitis, and here the pictures for Acanthamoeba keratitis, bacterial keratitis, fungal keratitis, and peripheral ulcer. Next, ma'am. Symptoms and sign. The hallmark symptom of infectious complication is pain, which differentiate from the infectious and non-infectious complication. And redness, discharge, photophobia, excessive tearing, blurred or decreased vision, swelling, foreign body sensation, white spot on the peripheral cornea, and decreased lens tolerance. Signs are corneal infiltrates, epithelial defects, corneal edema, neovascularization. And next one is next ma'am. And treatment. First is immediate removal. Immediately ask the patient to stop wearing the contact lens, and lubrications. Use preservative-free artificial tears, and then medication often requires topical antibiotics to target the bacteria, and corticosteroids for reduce the inflammation prescribed by an eye doctor. Third one is hygiene. Clean or replace the lens case and instruct the patient used to refresh solution and practice a strict hand washing. And next, steroids used cautionally later in treatment to reduce the inflammation and scarring. And surgical option, it is rare. For severe and non-responsive cases, a corneal transplant can be performed. And prophylaxis, long-term oral antivirals can prevent herpes recurrence. Next one. Here is my reference. My acknowledgements, Professor Ramprasat Kanagraj sir, Dean of Optometry Education, VIOR, and Professor Preetha Ramprasat ma'am, Principal of VIOR Salem, and Dr. Agarwal Institute of Ophthalmology Grand Rounds Organizing Team, and Dr. Agarwal Hospitals, Crumpet Ranch Ophthalmologist and Optometrist. Thank you.
Thank you. It was a wonderful presentation. So you have taken a lot of efforts in putting together this PPT, and you have included everything about the signs and symptoms and everything. Good presentation, Niranjana.
Thank you, ma'am.
So, Niranjana, it was can you hear me?
Yes, ma'am.
Okay. So, very well presented, and you have covered most of the points.
Yes, ma'am.
So, I have few questions for you. So, this
Okay, ma'am.
patient came with complaints only in the right eye. Correct?
Yes, ma'am.
But the left eye also has symptoms, shows signs,
Yes, ma'am.
right? So, what do you suggest, with respect to examination?
Yes, ma'am.
Okay, how important do you think slit lamp examinations for a contact lens patient?
Ma'am, the patient has an inflammatory process which are still going on both eyes, ma'am. But right eye has more because right eye's slit lamp examination shows marginal infiltrates in 4, 7, and 11 o'clock position with overlying epithelial defect, ma'am.
Okay.
Then the left eye. That's why patient has symptoms in right eye, ma'am. If the patient leaves the left eye as it is, it will lead to severe symptoms and infection, ma'am.
Right.
Left eye also will develop, ma'am.
So, yeah, so I want to highlight that even though the patient is asymptomatic, right? So, this process would have started long ago, even in the right eye. And only when the patient had very severe symptoms of pain, redness, he has come to the hospital. And even in left eye, he doesn't seem to be having any complaints, right? So it is very important for every optometrist to examine the eyes at least once in 6 months, even though the patient, obviously this patient is not so compliant. Okay, because I
Okay.
see that he is not wearing spectacles in every
Okay.
visit. I don't know, with, other than contact lens wear, there is no mention about spectacle cover or anything. Is he even wearing spectacles? Does he have a spare?
No, ma'am.
Okay. So, seems to be a really non-compliant patient. I don't know how he manages apart from wearing
Actually, this
contact
point is
lenses.
very important, what you have asked, whether this patient has spectacles. So definitely every contact lens user should be told that they should have a pair of glasses, because otherwise they will end up overusing the contact lens and it could lead to serious complications. Are you
Right.
sure that the patient does not have glasses, Niranjana?
Yes, ma'am. I am sure, ma'am.
Okay.
Yeah. So we cannot blame, we can't even mention this as a contact lens induced keratitis then. It is mostly a patient induced keratitis, right? So, and also you can see that history is incomplete, right? Can you tell me what other questions would you ask in history for such a patient?
In contact lens, ma'am.
Yeah, this particular patient, what questions you would have asked?
I can ask the wearing time, how many hours she worn the contact lens, and when she last opened the case, and what solution she used. Then, how does the patient clean the contact lens solution, contact lens, and does she clean the case? And
Hello. Right. So it's very important that you ask about how she cleans, like how many times she cleans and how long she wears. More than asking about how long, you should actually ask when she started wearing the lens and when does she remove, specifying the time. So that most of the time, people do not count. They just say I wear for 10 hours. But if you think about wearing starting at 8 o'clock, probably removing at 10 o'clock or so, it is almost 14 hours. So, and this being, what kind of a lens is this? Hydrogel, correct? We
yes, ma'am.
cannot wear, yeah, so we cannot wear it for more than 10 hours. And the patient is also a computer worker. So there is also a possibility of dryness happening. So, there are so many things going on in this particular patient's eyes, so many causes possible. So that's the reason why I wanted you to put all types of complications that could happen if the patient is not compliant. Okay.
Okay.
So I would request all optometrists and students to, take this into mind and ask for proper history. And also, once you finish the case, give proper recommendations, like how long the patient has to wear the contact lens, how many times to clean the lens, how to clean the lens, right? And also to replace the lens case, and not to change solution, not to leave the lens bottle open, and main thing, hand hygiene, and to keep a spare spectacles, right?
Okay.
All this is very important. And apart from that, you can also talk about visual hygiene whenever you come across such system workers. Anybody can follow that, but in this particular case, definitely needs vision hygiene. You can advise about blinking. You can give lubricating eye drops along with contact lens wear, and not to overwear the lens. Okay. Many people also do this, like they 1 month pack, they may extend it for about 2 months or so. So even that could be a reason. We really don't know. Okay. So what do you mean by infiltrates?
Ma'am,
The others can also post your answers in the chat box or unmute and say, yes, Niranjana, you started to say, you can continue.
okay. Infiltrates means a white spot or clusters of inflammatory cells with seen in the edges of cornea, ma'am.
Okay. So how does it look like in slit lamp? Are
Yes.
they visible without slit lamp?
No, ma'am.
Can you see?
In slit lamp, it will see small white spots like
Okay. You're right. So it can be central or it can be in the periphery. In your case, it was mostly in the periphery. If it's more of an acute, recent onset problem, had it been in the close to the visual axis near the pupil, it represents a chronic condition. Okay, but how do you differentiate an infiltrate from an opacity? Opacity also looks white. So what is the difference between an infiltrate and an opacity, corneal opacity?
ma'am, infiltrates inflammatory cells தான் ma'am infiltrates அந்த clusters form ஆயிட்டு வந்துட்டு white spots இருக்குது.
Can you speak in English? There are so many people attending from other states.
Infiltrates are the clusters of inflammatory cell, ma'am, where opacity is different from this.
How? What are opacities? Opacities are healed conditions. These are basically scars. Okay, there was an infection or it could be an inflammation. Something happened before and it has already healed. And mostly patient will not have symptoms of pain, redness and all if a patient has opacities. There might be glare, there might be reduced vision if it is closer to the visual axis. But infiltrates, it's not like that. You definitely have symptoms like this patient reported. Okay, so you need to compare your symptoms and signs together. If you see a white spot, you should be very watchful, because find out if the patient has any symptoms. Sometimes, as this case, they may not even have symptoms. Asymptomatic left eye, but that eye also had marginal keratitis. But you need to look for ciliary injection, right? And photophobia if it is there, or if you see watering. All those are characteristic features of corneal infiltrates. Okay, symptoms may not be there, but signs will be there in case of infiltrates. But opacity, symptoms will not, most of these symptoms that patients say will not be there associated with an opacity. Okay, opacities are harmless, but infiltrates are very harmful. Then, in the patient, if they continue to keep wearing this lens, this inflammatory process will become an infection. Okay, and as you can see, this patient after November 20th has not come back to you at all. So probably the condition healed with the medications, and we don't know, God knows what he is doing with the contact lenses. You may have to call from the branch to find out how he is doing. Okay, but it's a very good case, and only thing I request everybody to take good history and document it in the file. Anything else, ma'am, you want to add?
So, Niranjana, have you seen the patient yourself, or you have just taken from the file?
No, ma'am, I'm not seen, ma'am. I
Okay.
just observed the case, ma'am, in second visit.
But you saw the patient at least once in person?
Yes, ma'am.
Okay,
Yes, ma'am.
fine. All right, okay. So one thing is, when you see the patient and when you see that there are some missing details, you can make use of the time when you meet the patient and get the missing details and note it down also.
Okay.
And as Preetha told, yes, it is important to contact the patient and find out how he is, and maybe a follow-up. If required, you can also join and call me after this presentation is over. We can discuss about this and get back to the patient with the consent of the ophthalmologist later. Okay.
In fact, I
Otherwise,
had
yes.
suggested Niranjana to call the patient, but I think it's approvals are needed for that. So,
Yeah. Hmm.
so we thought we'll present and then take this process.
So all the inputs given were done by Niranjana, or she has also got inputs from Preetha?
Niranjana?
Ma'am,
All the inputs given in the PPT, it was done by you, or you got inputs from others also?
Preetha ma'am also helped, ma'am.
Okay, so yes, thought so, because it's a very well organized PPT with all the signs, symptoms, and everything. Very good presentation. So I encourage all the other interns also, when you come across some interesting case, please note down the MRD number and follow-up visits. Make sure you are in touch with the patient details so that it will be useful. We are going to come up with a case presentation competition, so where everyone will have an opportunity to submit your case presentations. Yeah. So any other doubts anyone has? Over to Jnana Bigai.
Ma'am?
Do you have any announcements to make or anything else?
No, ma'am.
Okay, fine. All right. So, can we get a thumbs up from everyone? So it was a wonderful session. So hope everyone liked it. Can we get a thumbs up? Okay. Thank you so much for joining, and thank you, Preetha, and thank you, Niranjana, for sharing with us your knowledge. And I'm sure it would have been useful for everyone.
Thank you, Jimmy and
Thank
DAO
you,
team,
ma'am.
Okay.
For this opportunity.
Thank
Well
you.
presented, Niranjana. Sally?
Yeah. Okay. Thank you so much,
ma'am.
Preetha.
Yeah, bye.
Bye-bye.
Thank you, ma'am.